Okay, I think that we are ready to do our last recording, last video of the actual bones of the skeletal system, and we're going to be talking on this recording about our appendicular skeleton. So we're going to look at a few different parts. We're going to look at the upper limbs and lower limbs, and of course also the parts that attach them to the axial skeleton. So those would be our pectoral girdle for the shoulder region and pelvic girdle for the hip region. So let's first start by reviewing the bones that make up the pectoral girdle. So we're going to see scapula and clavicle. Scapula being our shoulder blade and clavicle our collarbone in layman's language. Notice that the humerus is not really part of pectoral girdle, but because it's so closely attached with that, we will discuss that as well. So the function of the pectoral girdle really is that it provides us first an attachment point for the upper limb to attach to the axial skeleton, and second, it provides our muscle attachment sites. And notice with the pectoral girdle how we have very large range of movement available there, but we do have a poor bony fit, so this is for that reason a lot of range of movement, but we do need soft tissues to hold these structures together. And we'll get to unpack that as well a little bit as we continue this discussion further. This large range of movement of the pectoral girdle can be explained by the evolutionary origins of it. So as we moved from 4 feet to 2 feet, we freed the upper limb, and utilizing these upper limbs became very, very important for us. There's a large range of movement, like I mentioned, and that can be really explained anatomically and I guess physiologically as well by the proportions of the parts that make up this bony fit. So we have a very large ball-like head of the humerus and a very small socket at the scapula. So the size of the ball exceeds that size of the socket, and that gives us this large motility at the cost of a little bit of stability. And let's unpack that a little bit more. And I have a few pictures coming up, so if anyone's squeamish, these are dislocations of the shoulder joint, so just be forewarned. I'll let you know when we've skipped over those. So, like I mentioned, it is really easy to dislocate the shoulder, especially if you're playing things like contact sports. So I have some graphic examples of that. Here we see glenohumeral joint that has failed to stay in place. Few examples. The issue with this really is not just the joint, but there's a risk of blood vessel or nerve damage as a consequence of that. And I also do have a couple of x-ray pictures here. We see normal glenohumeral joint, and we can compare that to a dislocated one. We can really see that head of the humerus, the ball-like head, and versus the small socket that it articulates against. So shoulder is really held in place by soft tissues, and for example, rotator cuff muscles are going to be important for us later on when we discuss those in relation to that. I wanted to also mention sternoclavicular joint that brings the proximal end of the clavicle in contact with the manubrium of the sternum. And notice that the scapula is not really directly attached to the ribs. It's only bony connection to the skeleton is through the bony connection via clavicle. So really, rather, it is held in place by muscles. And let's have a look of clavicle. So our collarbone really quickly here, we're seeing that it's kind of S-shaped when we're looking down from the top-down view. And we can identify a few different portions. We can identify the proximal or medial end that articulates with the manubrium of the sternum. And we can see the distal lateral end that articulates with the acromial process of the scapula. So you might ask, what's the function of the clavicle? Well, many muscles anchor to it, including ones that hold the scapula. It also transmits forces to and from the upper limb. And in clinical setting, we might see that often this is broken when falling down and trying to catch oneself with an extended arm, because this really forms in this series of bones that would transmit those forces, then the weakest point, and that's why it would be the clavicle that would snap. Here we're seeing a scapula, so also in layman's language known as our shoulder blade. This is going to be an anterior view for us, and few parts of the scapula that I want us to notice. I want us to notice the borders of the scapula first, so superiorly or superior border at the top, a lateral border at the side, and medially, close to midline, the medial border. We can also see the glenoid cavity, so the socket. This is small in relation to the head of humerus, as we saw earlier on. And let's flip over the scapula and see what we can see on the posterior aspect. And a couple of things that I wanted to highlight from here. We would see our spine of the scapula. This is this ridge running through, and we often identify structures in relation to it. We will also see acromion. This is where the clavicle attaches to the most lateral projection. We can see coracoid process, so biceps muscle, for example, attaches to it. We see subscapular notch, the depression, for example, for nerves to pass through. And I wanted to talk a little bit about the term fossa. So fossa was an anatomical term, a medical term for area or depression. So we can describe those structures or areas in relation to that spine that we just saw. So we would see supraspinous fossa above the spine and infraspinous fossa below the spine on this picture. And let's go back to the anterior side. Using that same terminology, we can also identify our subscapularis fossa. So what we're going to do next, we're going to go through the upper limb, and we're going to see that there's going to be 30 bones for us to consider. Wrist and hand represent most of those bones. In fact, I think 27 of those 30 bones. And the first bone that we're going to look at is the first bone proximally from the scapula. That's going to be our humerus. And what we're seeing here on the picture is going to be humerus of the right arm. So on the left-hand side, we're seeing an anterior side. And on the right-hand side, you would see the posterior side of this right humerus. Let's look at different parts of the humerus a little bit so we can see the head of the humerus. This is at the proximal end, and this is what articulates with the glenoid cavity of the scapula. And like you can see here, the scale is really important. The head of humerus is rather large. We can also identify a few bumps at the lateral proximal end of the humerus. So we see greater tubercle, which is bigger of these two, and lesser tubercle, which is the smaller of these two. And many rotator cuff muscles will be attaching to those as we discuss them. We'll also see two necks, actually. We see an anatomical neck, which is anatomically separating the head from the rest of the humerus. And then we have something that's described as a surgical neck, because this is often where the fracture takes place. We can also see kind of midway, halfway down, a deltoid tuberosity. This is a bump where the deltoid muscle attaches to as it wraps around the shoulder. And we can also see radial groove on the posterior side. This is where the radial nerve would run. And at the distal end, few parts to notice. We have trochlea at the middle, epicondyles as the medial and lateral ones, really important muscle attachment sites. And we can also see capitulum at the anterior lateral side. I want to zoom in a little bit to the elbow joint region. So the term fossa, depression, is going to be useful here as we're naming parts. And really, I think that what this diagram or picture shows us really nicely is that elbow is a rather complex joint, because actually it is multiple joints put together. So it's a little bit more complex than people often give it credit for. Let's keep continuing down the upper limb and look at the forearm. So we're going to see ulna as the medial of the two forearm bones. Again, remember your anatomical position. That's why it was important that we learned that. And we're seeing on this picture again, on the left-hand side, the anterior view, on the right-hand side, the posterior view. Let's keep going onwards and I highlight a couple of structures from here, from the proximal end, the olecranon process that grabs the trochlea of the humerus on the posterior side, almost like a cup-like structure. And then the trochlear notch that articulates with the trochlea of the humerus. We also can see radial notch where the ulna and radius articulate together at proximally, and same at the distal end. We can also talk about the head of the radius that articulates with both humerus and ulna. And we see the radial tuberosity, this bump where the biceps muscle, for example, attaches to. Let's have a look of the hand. Here we're seeing right hand on the left-hand side, again, anterior view, on the right-hand side, posterior view. And we see our 8 carpal bones that make up the wrist. So we see our scaphoid, lunate, triquetrum, and pisiform, followed by trapezium, trapezoid, capitate, and hamate. There's many mnemonics to remember those, so you can look them up yourself. Some of the ones that I use are probably a little too rude to share. We also do have 5 metacarpals that make up the palm region of the hand, and they're numbered from the thumb to the little finger. And finally, we're going to see our phalanges, our fingers. This represents 14 bones, with pollex being the thumb and all other digits then being the fingers from 2 to 5. And I think that really brings us to the end of everything that I wanted to cover as it comes to the upper limb. So what we're going to do next, we're going to look at the lower limb, and we're going to start with the pelvic girdle, the hip region, and then work our way through from there. So there's going to be 3 different hip bones and sacrum that form this region for us. Ilium is going to be the most superior one. Ischium represents the posterior inferior facet. This is really the sitting down portion of the bone. And then we have obviously the pubis anterior. A couple of different parts from the pelvis that I want to highlight. Acetabulum is the socket, the head of the femur joins to. This part, we have the body, the large portion of the ilium, largest part, iliac crest, which represents the superior margin of the hip. We also have this opening through which the baby's head will pass, and this shape can be used to a certain extent with certainty used to determine whether the individual whose skeletal remains we're looking is a male or female. We also see pubic symphysis, which is the cartilage, and we discussed that earlier on in our studies that separated when the woman was ready to give birth to kind of give a little bit more space on that opening. And finally, pubic angle that helps to sometimes, again, to a certain extent, us to determine the sex of the skeletal remains that we're working with. I don't think that you really need to know this. I've labeled here also the greater sciatic notch and lesser sciatic notch. I think that goes a little bit further from what I would expect you on this course, but I do want to discuss the lower limb bones. And let's start with the femur, which is the only bone of the thigh, and it really is the strongest and longest bone in the body. And 2 different parts of the femur. We see the head that articulated with the acetabulum of the hip. We see the neck that's often fractured, and we can also see greater and lesser trochanters, which are the muscle attachment sites. Distally on the femur, we see epicondyles and condyles. These are again important muscle attachment sites laterally and medially. Fossa between these condyles, and on the anterior side, the site for the patella, so the kneecap to articulate to. Let's look at the leg, and again we're seeing here right leg from the anterior view. Do notice as we start this review of the leg portion that it is the tibia that carries the weight from femur to the foot, whereas the fibula is kind of more of the lateral aspect, not contributing to the weight carrying. Here we are seeing the medial and lateral condyles as before. From the fibula, we can see the head and we can see the lateral bumps. From the foot, what we're seeing here, we're looking down from the top on the right foot. So a few different parts to highlight. First, our tarsal bones. So this is 7 bones that form the ankle. We're also going to have our phalanges, 14 bones in total that form eventually the toes, with the hallux being the big toe. And I think that brings us to the end of our rather speedy and busy review of the appendicular skeleton. I know it was a lot of material. Like I said, really the best way to learn this is either by using diagrams, using pictures, coloring structures, or even looking at models. We'll try to do that in a classroom. But remember, you again do have that tutoring center with the models available for you outside the class time. I know it's been a busy one. I appreciate you. So thank you. And I look forward to seeing you throughout the week in the class.